Thiazide diuretics in hypertension. Here's a pharmacology paradox. One diuretic can prevent kidney stones, increase blood calcium, cause gout, raise blood sugar, and yet remains one of the first-line drugs for hypertension. That drug is the thiazide diuretic. In this video, you'll understand exactly why these seemingly contradictory effects occur. Thiazide diuretics, including chlorthalidone and hydrochlorothiazide, are among the most widely prescribed drugs for hypertension. Their primary site of action is the distal convoluted tubule of the nephron. Mechanism of action. Thiazide diuretics block the sodium chloride cotransporter in the early distal convoluted tubule. As sodium and chloride reabsorption decreases, excretion of sodium, chloride, and water increases, producing a diuretic effect. Initially, this reduces plasma volume, leading to a fall in cardiac output and consequently blood pressure. However, this is only the early phase. With continued therapy, thiazides reduce peripheral vascular resistance, and this becomes the main mechanism responsible for sustained blood pressure control. The calcium exception. Unlike loop diuretics, thiazides increase calcium reabsorption in the distal convoluted tubule. As more calcium is reabsorbed back into the bloodstream, serum calcium levels rise, while urinary calcium excretion decreases. This seemingly simple effect has two important clinical benefits. First, by reducing urinary calcium loss, thiazides help prevent recurrent calcium kidney stones. Second, retaining calcium may benefit bone density, making thiazides a useful option in patients who are at risk of osteoporosis. So, remember this important exception. Loop diuretics lose calcium, whereas thiazide diuretics save calcium. Therapeutic uses at a glance. 1. Hypertension. Thiazide diuretics are commonly used as first-line drugs for mild to moderate hypertension. 2. Edema. They are used to treat edema associated with congestive heart failure, liver cirrhosis, and renal disease. 3. Nephrogenic diabetes insipidus. Thiazides reduce urine output by causing mild volume depletion, which increases proximal sodium and water reabsorption. 4. Prevention of calcium stones. They decrease urinary calcium excretion, helping prevent recurrent renal calculi due to hypercalciuria. Therapeutic use. Hypertension. Thiazide diuretics are first-line agents for the treatment of mild to moderate hypertension. They are highly effective, inexpensive, and have consistently been shown to reduce cardiovascular complications, including stroke and heart failure. Initially, thiazides lower blood pressure by reducing plasma volume. However, their long-term efficacy is mainly due to a sustained reduction in peripheral vascular resistance, making them one of the cornerstones of antihypertensive therapy. Why thiazides work in nephrogenic diabetes insipidus? If thiazides are diuretics, why are they used to reduce urine output in nephrogenic diabetes insipidus? The explanation lies in mild volume depletion. Thiazides initially cause a small loss of sodium and water, producing mild volume depletion. In response, the body compensates by increasing proximal tubule reabsorption of both sodium and water. As a result, less fluid reaches the distal nephron, where the defect in nephrogenic diabetes insipidus exists. Consequently, the net urine output decreases, despite the patient receiving a diuretic. So, remember, thiazides paradoxically reduce urine output in nephrogenic diabetes insipidus by increasing proximal tubular reabsorption of sodium and water. Adverse effects. The first is hypokalemia, caused by increased potassium excretion in the urine. Clinically, this may lead to muscle weakness, cramps, or even cardiac arrhythmias. Another common electrolyte disturbance is hyponatremia, resulting in low serum sodium, particularly in elderly patients or those receiving higher doses. Thiazides can also cause hyperuricemia by reducing uric acid excretion. As a result, they may precipitate gout, making them unsuitable for patients with recurrent gout attacks. A unique feature of thiazides is hypercalcemia, which occurs due to increased calcium reabsorption in the distal convoluted tubule. This property is beneficial in preventing calcium-containing kidney stones, but may worsen pre-existing hypercalcemia. They may also produce metabolic adverse effects, including hyperglycemia and hyperlipidemia, although these effects are usually mild. Key takeaways. Before we conclude, let us quickly revise the most important examination points about thiazide diuretics. First, the site of action is the distal convoluted tubule, where thiazides inhibit the sodium chloride cotransporter, producing natriuresis and lowering blood pressure. Next, remember the 4 clinical uses. They are first-line drugs for hypertension, useful in edema, effective in nephrogenic diabetes insipidus, and help prevent recurrent calcium stones by increasing calcium reabsorption. Finally, always remember the major adverse effects to watch for: hypokalemia, gout due to hyperuricemia, hyperglycemia, and hyperlipidemia.